will do the side port using the trypan root eye for the ALC. While the ALC is being stained, we can do the peritomy in the meantime. First, we'll cut the conjunctiva, followed by the tenons, and we'll go beneath the tenons and cut around the limbus. To exposing the sclera for the incision. Putting the 2% HPMC OVD in the anterior chamber and over the cornea for better visualization for the capsular axis. Doing the capsular axis with the 26 gauge bend needle cystitome. First we'll do tear the linear and then make it as a flap. This is a slightly eccentric capsular axis, and the grade is less, so we are towards the smaller side. Now we'll lie the superior rectus to better exposing this sclera. This is a Brown's incision. Will groove in the half thickness and will liggle it in the cornea. And gentle sweep movement towards the side, keeping in mind the contour of the globe. Same towards the other side. So inner incision is always bigger than the outer incision. Now using the keratome, we'll go to till the anterior limit of the tunnel and then depress and enter, and we'll cut while going in.
Now you notice that the inner there has been dissection inside the tunnel, right? And the inner incision is larger than the outer incision, and that largeness you can control. If you dissect more obliquely on the sides, you can have a still larger inner incision, depending upon your anticipation of the nucleus.
To wheel out the nucleus in the AC, put some OVD behind the lens and above the lens to protect the endothelium and the posterior capsule. We're using a wire vectors to deliver the nucleus from the AC. Now we'll using a Simcoe cannula for the cortical wash. after the cortical wash, we'll put some OVD for maintaining the pushing the PC back, and we'll implant a legit PMMA IOL for the patient. Will the leading haptic go in the bag? And dialing the following haptic in the bag. So pushing the iris to see whether the haptics are in the bag or not, and thorough washing the anterior chamber for the OVD, trimming of the OVD and the angles. Now we'll be injecting intracameral antibiotics.
So that was an excellent display by Adarsh about SICS case. I would welcome now ma'am, Professor Vinita ma'am, Professor Madhu ma'am, Dr. Vandana ma'am, to please add some inputs about the case discussion.
First of all, that was an excellent surgery done by Adarsh. We must congratulate him. We must congratulate. One thing, Adarsh, you see, and you made the tunnel so beautifully, and you can see some hyphema trickling in, right? So if you wash and put some air, then that would go away. Yeah, very good. So that was an excellent surgery and demonstrated so nicely by Dr. Adarsh. Can we have some questions from the audience? Hello?
Yes, ma'am.
Yeah, I was asking the audience if they have some questions.
Yes, I think it would be a wonderful thing to for the audience to actually ask their questions, and they can direct it to Adarsh and also to the chair as to what would be the teething steps as to develop the confidence to one do a case and then to do a case as live.
Adarsh, heartiest congratulations, you've done a great job. Now, before injecting intracameral, if Adarsh had injected a little more fluid in the anterior chamber and made it firm, then the tunnel will tightly close. Here what happens is the fluid goes in the angle. So the lower lip comes and opposes like that. You see my hands? The lower lip is like this, right? It's stuck here. So it comes, the moment fluid comes here, it becomes tight. Once that fluid, like in dissect, it attaches. The similar way, this flap also attaches tight. And after that, you inject your intracameral, soften out some this thing and inject intracameral. And if there is actually blood, it should be coagulated, because if you leave anything which is bleeding outside can trickle in, because patient can actually rub. The moment you put pressure on the top, it can go in. So under the conjunctiva, it will clot. But in that case, either you wait till the blood clots, or else make a chamber firm. The moment chamber is firm, then it just comes and it snaps up like a lock. So that point is there. And then second point was that hydrate your side port, because you are, when your kids, you're not titrating the size of it. He is very well titrated, calculated, but sometimes it's bigger, sometimes it's smaller. So good width is that whatever is the thing of 15 number blade, whatever that you use, whatever it's called, crescent blade. So when the crescent goes in at the maximum, that is the correct size of side port. No increase, no decrease. Through that Simcoe goes. The code word is that. But please hydrate, and I would say again hydrate because it's very important. It is on the temporal side where the conjunctiva is, where the lid is not covering your eye. So this part is exposed all the way along till such time the wound heals completely.
Beautiful surgery. I mean,
Honestly, I'm impressed.
yeah. So, I mean, I have not performed a live surgery yet. So he is already performing at the stage of the residency, and he had very nice clarity of thoughts, very calm and composed throughout all these steps, and beautifully performed surgery. A lot of learning points all ma'ams have disturbed. I'm not a cataract surgeon anymore, so but I was just waiting that some opportunity for me would arise, but nothing for a retina surgery to come in. Beautiful surgery.
So first of all, thank you everybody for inviting. Thank you Devakant, thank you ma'am, thank you Vinita ma'am, and your expert comments I'm sure are very, very helpful. Adarsh, a huge round of applause and big congratulations. Actually, it was very, we all are standing and giving you a standing applause. And most importantly, the way you were continuously, like I was in fact asking Parijat whether he is operating and he is giving his steps himself or there is somebody else who's giving that. That's also commendable while doing a surgery, not getting tense, so coolly, calmly, letting us all know the steps that you are performing. So it was wonderful. My only thing was that when you made the scleral bed and scleral flap, after the conjunctival flap, there was slight bleeder points. So because you are a pro now, we can all make it. But sometimes it might get a little difficult for the ones who are learning to see it, to get that continuous that bleeding. So pottery can.
Put the camera on. The camera on.
On axis. I can't see us.
So this is not for you, but this is for the learner first year residents, that a slight light pottery can help to reduce the bleeding points and make the surgical field a little more visible for easy dissection of the tunnel, and maybe that can also reduce the chances of hyphema post-operatively. So that can help, but then we have to be cautious that the pottery that is being done is not very, very heavy, because otherwise it can lead to more harm by ischemia. So once again, congratulations, not only to you but also to your mentors, and also to, yes, definitely ma'am, the two senior ma'ams, and also to Yossi led by Devakant for this wonderful opportunity. Congratulations.
That is, you are not going. You should not take your camera inside the AC. It should be in the side port wound only. Inject it in the side port wound. Just to hydrate your side port wound. It should be like that only. Don't. It should intra-camera antibiotic is the last. After that, you don't take any instrument inside your eye. Hydrate your side port wound very nicely, and then take your camera. Inject antibiotic. It's like just you hydrate your stomach wound, side port wound. Stomach hydration is done. Antibiotic is injected like that only. It goes inside the eye. The wound is going. Finger is going. Antibiotic is like that only. Please don't take any instrument after that inside the eye. And जो hyphema हुआ था इसलिए he should have injected air bubble, and he could have waited for 1 or 2 minutes, and then again or he could have used Simcoe after that. He could have used Simcoe and again hydrated the side port. Very, very brilliant. I've seen him, मतलब his brain. इसमें ये है तो इसमें मैंने क्लिक करके एक बार देख लो, इसमें आके इसमें मैं ये कर रहा हूँ, यहाँ पे ये हो गया. Complications होने नहीं देता.
Okay, so we are ready now for the second case. Dr. Devakant?
Yeah, please go ahead. Let us know
Okay,
about the
so
case. Yeah.
So the second case